This lecture will cover denture bases and tooth replacement options for the RPD. The denture base supports and retains the artificial denture teeth. It provides aesthetics to the prosthesis when tissues need to be replaced due to destruction in the area. The acrylic base comes in a variety of shades, and staining may also be applied to make the acrylic match the natural tissues. The base helps distribute force and stress to the underlying ridges. It stimulates the tissues placed under functional stress. When forces are within its physiologic limit, the ridge maintains its form better than similar tissues suffering from disuse. One type of denture base is constructed of acrylic resin. The resin is a heat or chemical activated polymethyl methacrylate. These resins are available in a variety of shades and can also be used to customize the gingival area to match the patient's natural tissues. The denture base can also be made of a cast metal alloy using cobalt chromium, gold, titanium alloy, or pure titanium. Acrylic resin is the most popular. There is a difference in the function of tooth-supported RPDs and the extension base RPD. They may differ in the materials also used for the base. In the tooth-supported, there's a span of acrylic denture teeth between two abutments where the forces are applied to the denture teeth and to the two abutments. When posterior teeth are replaced, depending upon the high or low smile line, aesthetics is only a minor concern, especially in the mandible. When anterior teeth are to be replaced, the base must provide aesthetics, support and retain the denture teeth, prevent horizontal migration of the natural teeth, prevent food traps, and stimulate the underlying tissues if possible. The denture base must contribute to the support of the prosthesis. The tooth abutments offer some support, but the residual ridge and tissues must also support the prosthesis. The base should be designed to extend and cover as much of the supporting tissues as possible without overextending the denture base. This ensures that there will be less pounds per square inch exerted on the tissues than when a small denture base is used. Patients want the base to be small. Demonstrate this effect by placing all four fingers flat on the back of the patient's hand and push. Then place the tips of your index and middle finger on the back of the hand and push. It hurts. They will get the idea of why your denture base may be larger than the one they are presently wearing. The flanges should also be as long as possible for horizontal stabilization, but cannot be overextended to violate the muscles in function. The maxillary must cover the tuberosity, and the mandibular must extend onto the retromolar pad. Some of the advantages of the acrylic resin base are: this base is aesthetically superior to the metal base. It comes in a variety of shades and accommodates for different races of people. You can add toners to make the denture base match the natural tissues and characterize it. It is lighter in weight, and for the maxillary arch, this may be an advantage. A big advantage is that it can be relined and repaired much more easily and inexpensively than the denture base, made of metal. If the metal base breaks, it may mean a remake for the denture. It is also easily adjusted when it's overextended or places pressures on the tissues. The cost of the framework is also lower than the metal base RPD. Disadvantages exist also for acrylic resin base. It is porous, so it traps plaque easier, and oral hygiene has to be a little more meticulous with it. It is lower in strength than the metal base, and it has low thermal conductivity. Some patients like to feel that hot from the coffee they're drinking, and you don't get that effect with the acrylic resin as you do with a metal base. And obviously they're more easily warped than the metal base partial. There are advantages and disadvantages of the metal base. The advantages include its strength. It can be kept thinner than the acrylic resin because of its strength. It takes up less room, so it is good for cases where the patient has inner ridge distance that's compromised. It adapts well to the ridges, but it should only be used on long-term, well-healed ridges that are ideal shape. The metal is dense, so oral hygiene is improved over the acrylic resin. Some patients like to experience hot and cold sensitivity when they eat. The thermal conductivity of the metal base is superior to the acrylic resin. The disadvantages of the metal base are it cannot be relined or rebased. This is a major disadvantage. When it no longer fits, it's pretty much a redo. That is why it must be done only on well-healed ridges that are well formed. The metal-based partial can be very heavy. Some feel that this is an advantage in the mandibular arch, as gravity and weight aid in stabilization of the prosthesis. It's very difficult to adjust this hard metal, so the impression technique is absolutely critical to a well-fitting prosthesis. A special impression technique should be used to get the master impression when this metal base is designed. We will talk more about that in RPD 2 lectures. It also will cost you a little bit more for this metal framework. Normally, a single tooth replacement is done with a fixed partial denture or an implant, but this is not always possible for the patient. Indications for an RPD are young persons whose pulps are very large may be at risk if fixed work is done. The RPD may be able to get them through that period of time to when finally the fixed work becomes feasible. Patients in poor health may find extended appointments very stressful, whereas treatment with the RPD may be less taxing for them. If the patient has poor periodontal health around the abutments, then a fixed restoration is not indicated. A partial denture can distribute the forces over the entire arch. At times, the space in the arch is not conducive to use of a fixed partial denture, whereas the partial denture or implants might be a better treatment. Implants are very expensive, and often patients cannot afford the treatment that is best for them. Also, severe resorption of the alveolar bone around the area would call for very long Pontics, and the RPD may be more aesthetic with the use of acrylic resin base. And lastly, finances unfortunately often dictate the type of treatment the patient receives. Denture teeth are available in multiple shapes, sizes, and shades to fit all faces. There are many companies providing excellent choices of denture teeth. Many have a shade guide compatible with a porcelain guide, which is convenient when you're doing crown and bridge along with the removable prosthesis. I suggest sending your pre-selected denture teeth to the lab at the time crown and bridge is being done. A close-up picture of the patient's natural tooth with a shade guide selection next to it will produce the best results. Teeth come in porcelain and various grades of plastic or composite materials. Porcelain teeth cause extreme wear when opposing natural dentition with the enamel or dentin surfaces. Acrylic resin and composite teeth are the ones most often used. The composite material seems to wear better against the natural tooth. You would like to have denture teeth that are compatible with the opposing dentition as far as wear resistance. So porcelain teeth should be placed against porcelain tooth restorations on the opposing arch. Otherwise, the weaker one will wear away faster. Resin teeth are easily adjustable, but the porcelain teeth are not. Teeth are also available in different anatomical forms. You can get non-anatomical or 30-degree, for instance, anatomical forms, which allow you to develop an occlusal scheme that fits your patient. More about tooth selection will be presented in some later lectures in the RPD course. There are 3 anterior tooth replacement mechanisms that we will commonly use. 1, we will see acrylic resin or porcelain teeth attached to acrylic resin base material. 2, the reinforced acrylic Pontic or wraps may be used. And 3, facings are called upon at times to restore an anterior area. The advantages of resin or porcelain teeth secured with acrylic resin base are, first of all, aesthetics. Both the teeth and the acrylic resin are available in a variety of colors. The teeth are also available in a variety of shapes and sizes. You can see some of the molds on the board shown on the slide. The resin base can also be used to restore lost tissues and provide a natural tissue appearance that's sometimes needed. The base can be recontoured to fit the needs of the patient when it's acrylic resin. It can be adjusted relatively easy, and the contours can be changed to accommodate the musculature. The denture base in acrylic allows also for a reline of the denture down the road when the ridge shrinks or you have some type of change. That's not true with the base that's made of metal. And the acrylic resin is easily adjusted when the denture sore spots or problems arise with the denture fit. The disadvantages of resin and porcelain teeth secured with acrylic resin base are, first of all, the resin base requires added bulk to the prosthesis because you have to have room for acrylic resin, base attachment, then more acrylic resin on top of it. So it does take up a lot of space. It's contraindicated for the single tooth replacement. That's probably the most common repair that may walk into the office, is where someone has placed one tooth on a partial denture and used base attachment to connect that one single tooth, and it breaks off. A high smile line may also show the borders of the acrylic resin, and that's not terribly attractive as far as appearance. Also, porcelain teeth are very difficult to adjust compared to the acrylic resin teeth when you're trying to straighten out some occlusion on a patient. The reinforced acrylic Pontic, sometimes called a wrap, consists of a denture tooth that has been hollowed out on the lingual so that a metal strut that projects from the framework can go into that area and then be covered by more acrylic resin to help retain the denture tooth to the framework. This is shown in the two pictures on the right. This is a very aesthetic type of replacement mechanism for denture teeth, but it has to be done on a good ridge. The advantages of the reinforced acrylic Pontic are these. First of all, they're exceptionally strong because they have that metal strut in them covered with acrylic, but they're only as strong as how the laboratory technician has prepared them. There has to be enough room where that strut goes into the tooth, and then the tooth can still be covered by a couple millimeters of acrylic for strength. They're very aesthetic. They look like they're growing out of the tissues, but they need to be on a nicely formed ridge in order to look natural. The occlusion is on the acrylic, so wear is not an issue on the opposing dentition, and as long as there's enough room there for strength, it's not a problem. They can be used in a somewhat restricted area, but if you have a really deep vertical bite, maybe a facing would be more advantageous for protection to keep that tooth from wanting to break off than the acrylic Pontic. There are some limitations with the reinforced acrylic Pontic. The ridge has to be well healed. You don't want to do this on a case where there's recent extractions, and I mean you should have months, and it should be a well-formed ridge if you're going to use this. The narrow resorbed ridge is not a good indication because oftentimes the Pontics look like they're almost like a ski slope coming out from the ridge. It really provides little support from the contact with the residual ridge. So that's one disadvantage. They're also very difficult to reline and get them to look right. So this has to be a well-selected case. Another option that we have for the anterior tooth replacement is the facing. The patient is shown in the upper left. She started out with an interim partial denture while she waited for healing to take place after extractions. This requires at least 3 months and preferably more. Then, when the ridge is stable, an impression is made. The final partial denture using facing replacements is shown in the upper right. The lingual of the facings is shown in the lower right picture. Note that the acrylic resin denture tooth has metal on the lingual up to the incisal 1/3. This protects the acrylic facing that is cemented on or cured onto the retentive component of the metal framework from being broken. The indications for a facing are large bony undercuts. If you have a bony undercut labial to the ridge and you don't want a flange to be sticking out, the facing's indicated. If you have a deep vertical bite where the lower teeth are very close to the maxillary ridge, you don't have room for acrylic and base attachment and more acrylic. The facing is just metal through there. Also, if spacing's a problem, like on this case we had before, if you had 4 incisors you were trying to fit in there, there would have to be diastemas, and it would be like 4 single teeth. The facing is the strongest of those restorations. If you have a single tooth replacement in the anterior, it should be a facing because it's backed by that metal and it's very strong. It doesn't break off as easily. If aesthetics is an issue, it's awfully nice and with a patient with a high smile line to have those teeth look like they're emerging out of the ridge. If the ridge loss is not extensive, then you can use the facing. And you do not want a long span. Anything longer than 6 teeth doesn't work very well. Here's our patient again on the left. She's a prime example where the patient has a deep vertical bite and very little space between the ridge and the lower teeth. You don't have room for acrylic resin to sit on the ridge, base attachment to be on top of that, and then more acrylic on the top of that because it takes up too much room. You need that metal on the lingual, as shown in the lower right picture, to go through that small space and to back those anterior teeth to keep them from breaking off. Acrylic resin and base attachment would not be as strong. There are contraindications to the facing also. If you have a large bony defect, as seen in this accident victim, you would not want to use facings. The facings would look very long, as shown in the lower picture. Now you might say, if the patient doesn't have a high smile line, what difference does it make? Well, it doesn't necessarily make a difference, but when you have a lot of bone destruction, sometimes you need that acrylic resin to help fill out the lip properly and give the effect that you want. So facings might be contraindicated in this type of situation. If you have a really large edentulous span that's greater than 6 teeth, facings would not be indicated. Or if you have a sharp bony ridge and you've had some resorption there, you can have, if you put facings, they might look like ski slopes coming out at the improper angle to give a nice aesthetic effect. And if you anticipate that you're going to need to reline this area in the future of the denture, then you definitely don't want to use facings because you cannot reline them at all. There are several ways of replacing posterior teeth. The first one, and most popular probably, being using acrylic or porcelain teeth on base attachment and base. There's the tube tooth, the braided post, metal Pontics, and the facing. Some facts about posterior porcelain and acrylic teeth on acrylic resin base. The majority of posterior replacements on RPDs are done with acrylic teeth and the acrylic resin base. On a Class 1 and a Class 2, the posterior teeth of the acrylic wear over time. You may see even a little bitty space between the teeth and the opposing arch. The patient loses his ability to chew properly, and you may even see a decrease in vertical dimension on the patient. That patient must be monitored carefully. The patient often thinks that once they get their teeth, it's no more dentist, yay, but the teeth and the denture base have to be monitored, and they can be replaced if it's a good sound framework. Porcelain teeth can produce significant wear on the opposing tooth enamel and dentin. They wear acrylic rather rapidly. They may wear other porcelain tooth surfaces like crowns. A general rule, though, is that like surfaces should oppose one another to get the minimal amount of wear. In the fabrication of a tube tooth, the denture teeth are set into occlusion with the opposing cast. The tube tooth consists of a denture tooth that has a channel cut away from the underside of the denture tooth. The framework is waxed against the opposing mounted cast with a nail head waxed onto the framework wax pattern that fits up into the channel of the denture tooth. The framework wax pattern is then cast and placed back onto the master cast. The denture teeth are then luted to the framework with acrylic resin or some type of cement. The tube tooth may be prepared with a metal finish line at the cervical of the tooth. This is not very aesthetic if there's a high smile line on the maxillary arch. It can also be made to butt up against the ridge as shown in that lower picture. The upper is probably stronger, but the lower is more aesthetic. The tube tooth indications are a single tooth edentulous space in the anterior without a deep vertical overbite present. If that deep bite is present, you may not have enough acrylic over the lingual in the area of that nail head, and it may risk being fractured. The more common selection of a tube tooth is a single posterior tooth where you want aesthetics. The tube tooth has a white occlusal surface, whereas the facing has a metal occlusal. The all-metal tooth would be very unaesthetic, especially in the maxillary arch. You may have a little bit of reduced room between the lower teeth and the arch above, but you have to have enough room for the metal to cover the ridge and the tube to be up through the center of the denture tooth that has had a channel cut into it, and it must have at least a couple more millimeters of acrylic above the nail head, or you should consider another tooth replacement like the facing or the metal tooth. Just to remind you, though, the contraindications for tube teeth are: first, if you have a deep vertical overbite that interferes with occlusion, you would need something more substantial like metal backing that tooth for reinforcement. Also, an area that requires a reline in the future is not a good indication for a tube tooth. Both the facing and the tube tooth have metal on the tissue surface and cannot be relined. Also, the width of the edentulous space, if it's insufficient to be able to place a denture tooth in that area and have the nail head come up through the middle of the tooth for reinforcement, then you might want to think in terms of a metal tooth replacement, but we wouldn't want those necessarily in the anterior of a Kennedy Class 4. The braided post indications are similar to those of the tube tooth. In its construction, it may be placed on base attachment, which allows for the prosthesis to be relined. It is constructed by twisting two pieces of rope wax, which gives the braid design, which creates retention for the tooth. It is used in the anterior or posterior area for reinforcement and retention of a prosthetic tooth. When you have a small space between teeth, there's not sufficient space to place the retentive mechanism of a tube tooth, maybe not the space to allow for an aesthetic facing, or the space to place a denture tooth on base attachment. In that case, you would use a metal tooth, which is waxed during the framework construction in occlusion with the opposing arch. Here's an example where base attachment was requested, but you really don't have enough room for a denture tooth to fit into that small area. You'd be just putting a little bit of a sliver of a white tooth in that area. You're just as well off to either do nothing in that area or have a metal tooth waxed into the framework at fabrication time. If you do this, mounted models should be sent to the laboratory at the time the framework is constructed so that they can wax that tooth into occlusion with the opposing arch. Sometimes we do what is called an overlay partial. in order to even out the occlusal plane. We incorporate the metal tooth into a rest that covers the entire tooth. The overlay partial is shown in the lower right picture. This is an example of a metal tooth that has been waxed when the framework is constructed. It's one that is done when you want a really strong posterior tooth and you're not concerned about aesthetics. You would not usually find this in the Kennedy Class 4 in the anterior section unless you've been cast in the role of Jaws in the epic James Bond movie. There are a couple of components of the partial denture framework that are important or related to the base, and they're the finish lines. An internal finish line is a butt joint that's created on the tissue side of the framework, and that butt joint is filled with resin, but the resin then, filling that butt joint, creates a smooth transition between the acrylic resin and the framework. The external finish line is a butt joint that's created on the tongue side of the framework. It is at the junction of the major connector and the base attachment, which is a minor connector. The purpose there is to form a nice ledge, and when the acrylic resin is finished, there will be a real nice smooth transition that is not noticeable to the tongue and irritating to the tongue. Have a great day today. The suggested readings for more information on the topics that we covered in the lecture are the 2 textbooks listed below. That's where the material came from. For the next logical progression of information, go to the lecture on Biomechanics of Removable Partial Dentures.